I'll be talking about surgical steps to toric IOL rotation. So if you're faced with a patient with postoperative astigmatism surprise, first thing you should do is don't panic. Repeat the manifest refraction until it's stable. Ensure that the IOL inserted was the one that you had planned. You want to check the current IOL toric alignment, the posterior capsule status that is still intact, and how long ago the surgery was done, and the model of IOL that was used if this case was referred to you. Now, when you're planning to rotate, confirm that the toric IOL only needs rotation and not exchange. Check the ocular surface because you may need treatment for the surface before biometry is done. Stand by a 3-piece IOL for the sulcus if the posterior capsule is breached. Rotate about 2 to 4 weeks to prevent re-rotation of this IOL. Keep in view the use of capsular tension devices, especially if you're dealing with a high myope, a high white to white, zonal weakness, or decentration of the IOL, in addition to toric misalignment. Anterior vitrectomy and triamcinolone acetonide may be needed if the posterior capsule is breached. Now, first thing you want to do really is to mark the reference axis, and there are many methods of doing this. The traditional method would be to use a slit lamp beam on axis, so you do not need to mark the toric IOL alignment axis thereafter. And if you just want to mark the reference axis, there are also many other devices, as you can see here, and you can really pick which you prefer. Now, you can also use what Graham Barrett has described, Toricam, which determines the axis of the corneal limbal marks that are used as a reference. It's important to mark the eye while the patient is upright and not when the patient is lying and sedated. Now, you can use a markerless system, or you may mark the toric axis of the IOL, and this is done either preoperatively at the slit lamp or intraoperatively. So you need to have a toric marker, and you can do this freehand, as you can see here in the picture, or you can use a device. It's important before you place your marks that you dry the eye so that you do not have a smudging and a blotch of ink. Use a fine marker, and even a Sinskey hook can be appropriate. Now, I'm just going to share with you what I call my no-fuss reference axis technique marking. You can see myself here wearing just a handicraft loops that magnifies about 2.5 times. My nurse assists me after instilling topical anesthetic into the patient's eye. The patient is seated up, and then I put on these loops, retract the lids so that it does not touch the lid margins, and then I just place this ink marker at 4 positions, as you can see here, 12, 6 o'clock, 3 and 9 o'clock positions. And you can see there are different types of loops that you can buy quite cheaply, really. And I'm just going to share with you how we do the toric axis marking when the patient is lying on the table intraoperatively. So I'm planning to mark at 80 degrees, and you can see my 4 marks already very clearly. I dry the eye, and then I'm just marking at 80 degrees with that toric ring alignment. Now, once you get to mobilization of the IOL, it's important to use retentive viscoelastic. I generally prefer to use dispersive viscoelastic because it really stays in the eye. And what you want to do is pick up the space between the capsule and the intraocular lens. This can sometimes be difficult if the lens has been in situ for more than a month. And you may need to have a microforceps to help you pick up that capsule. Be sure you don't use a sharp one because it may rip the capsule edge. Now, once you get into the space between the capsule and the intraocular lens, you then sneak in your cannula under the capsule and then slowly inject the retentive viscoelastic into that space and advance your cannula tip so that you can get the viscoelastic going around 360 degrees and behind the IOL optic. Now, the next thing to do is to use a Sinskey hook to nudge this IOL optic and then to free up the lens completely. What you want to really focus when you are doing this mobilization dissection is to look for the haptics where it may be strongly adherent, especially if the lens has got positioning holes, where fibrosis may have grown through the holes to cause adhesion between the anterior and posterior capsules, and also around the tip of the haptic where there may be a knob. And sometimes this actually gets trapped and you may have to dissect this free with 2 instruments, and if adhesion still persists, you must be very careful and not resist yanking really. Once you've got the capsular bag open completely, you just ensure that you are able to rotate the lens to a new position. So I'm going to share with you this first video of how we do a rotation of axis from 20 degrees to 90 degrees at 1 month post-operatively. So you can see that in this particular video, there is hardly any capsular fibrosis in this multifocal lens with the toric axis, and you can see the markings of the toric lens. So first thing to do is inject viscoelastic. Resist injecting too much, because remember, you're going to inject some behind the lens. So you can see, because there's hardly any fibrosis, the first maneuver with the Sinskey hook was quite easy, but this other haptic here actually is a little more tightly adherent, and I'm going to come in from a different direction to try to rotate this haptic. And you can see here we have successfully rotated it. So generally I do 3 incisions, okay, so it is actually at equally spaced 120 degrees apart. So you can see I'm rotating this, and now it's spinning quite freely without resistance. I don't see any capsule striae, which I had seen at the outstart when I started to do this rotation. And it doesn't matter which paracentesis you come through, whichever is comfortable for you. I'm comfortable rotating with my non-dominant hand, and you can then just rotate to the 90 degrees. And in this case, because the lens was not really that adherent to the posterior capsule, I hardly had to put any viscoelastic into the bag behind the intraocular lens. So it's important to remove the viscoelastic completely, and I'm trying to still keep to the small paracenteses, and that is why I've done a bimanual kind of aspiration of the viscoelastic. It's important to make sure if you put viscoelastic under the intraocular lens that you remove it completely so that this lens does not re-rotate. Tap the lens against the posterior capsule, check the pressure that's not overinflated. Now let's have a look at this second lens. It's a IOL that's rotated at 1 month, and you can see already some capsular fibrosis, and it's actually positioned at 180 degrees when intra-op it was actually left at 156 degrees. So you can see my 4 reference marks, and here I'm marking the 156 degrees that I wish to intend it to rotate it to. So again, inject viscoelastic first into the anterior chamber, pick up the space between the anterior capsule, which is slightly fibrosed here, and I'm struggling a little, and the IOL. And you can see going near the haptic sometimes does help, because you can push against the haptic and not fear plunging through the posterior capsule. Next is the Sinskey hook coming in to help to free up the haptic, and you can see, even though you're not seeing the haptic entirely, you can feel. All right, so you don't want to push too deeply so that you do not hit the posterior capsule and breach it, but you just want to latch on to the haptic and maneuver it from the haptic optic junction towards the tip. All right, you can see I'm progressively reaching the tip. Although I'm feeling it and not seeing it, I know I'm making progress, and now you begin to see it. So I'm doing the same for the other haptic coming in from a diametrically opposite position, and again I'm doing the same. And you see the striae now on the posterior capsule, and I'm having some difficulty. Okay, so I do not persist. I'm going to inject some more dispersive viscoelastic here to create that space, to open up the space between the anterior posterior leaf, and I'm trying again to release this haptic well. The knob there is stuck. Okay, so I'm going to have some additional help come in. With my other hand, inject viscoelastic as I dissect again, and I'm just trying to pull forward the haptic, and you see I was successful in a bimanual technique. So it leaves me now just to rotate the lens to the correct position and then remove the viscoelastic, and you can see this lens is already just short of that 156 degrees that I intend to rotate it to. I'm now removing the viscoelastic and then finally adjusting the lens to the desired position. And once it's in alignment, I'm happy. I seal the incisions and then make sure that it is not overinflated, and I tap it into position. Now this patient that you see next is a patient that has got a multifocal toric lens, and you can see, in addition to the fact that this is off the axis I intended, the lens is not centered. Okay, so of course with the multifocal lens it's decentered, we know that it can cause aberrations that actually induce further astigmatism and a blurring of vision. So I'm going to explore this case, and in fact, just to point out already, you can see some striae here on the posterior capsule. So we start again with dispersive viscoelastic, and then I'm trying to nudge this lens, and you can see the striae more obviously here. All right, inferior nasally, I'm sitting temporally, and I'm just nudging the edge of that IOL, and this happens to be a plate haptic lens in a very high myope, and I'm injecting viscoelastic to open up the capsular bag, and I'm doing the same for the opposite side, so that I'm trying to release the lens as well as inflate the bag. And now I'm injecting a plain capsular tension ring into the capsular bag. It's important to the bag really distended so that this slips nicely into the capsular bag phonics, and then you can see now that the lens is able to nicely and easily center, and now it's just a matter of rotating that lens into the appropriate position from 45 degrees to 80 degrees, and you can see my marking at 90 degrees. I'm going under the intraocular lens, remove all the viscoelastic. This is a plate haptic. I need to really remove from not just the optic but also the haptics, and then just ensure that the incision is nicely sealed. And what you saw was just that suture that I cut because I was concerned that I may have problems inserting this capsular tension that may not skirt around smoothly in the capsular phonics, because this is already a month post-operatively, and that suture would just help me to overcome any adhesions in the capsular bag by just retracting it and reducing the radius of this capsular tension ring. So you know, when we do a rotation of the lens like this, the most fearful thing is really to have a posterior capsule rupture that we cannot handle. So it's important to have adequate retentive viscoelastic, and you want to always fill this up behind the lens so that the lens can rotate freely. It's important to ensure that the lens is completely freed from the capsular bag, and you want to focus really on releasing the haptics. Do not forcefully rotate an incompletely freed intraocular lens to prevent zonal adhesions and accidentally ripping the posterior capsule. Watch the irrigation aspiration tip behind the intraocular lens when aspirating the viscoelastic, because the posterior capsule does not behave exactly the same way as it does following cataract removal. This tends to be a little less distensible and stiff because of fibrosis. So also, you do not rotate before 2 weeks generally, post-operatively, and it's usually best before 4 weeks because fibrosis may set in. Now if you rotate too early, it may re-rotate because the capsular bag is still distended. You remember to always completely remove viscoelastic from behind the intraocular lens after the repositioning. You want to tap the optic against the posterior capsule to hope that it would adhere, and then leave the bag slightly deflated and avoid ocular hypertension post-operatively, otherwise the lens may rotate even after repositioning. Have the patient lie still for 1 hour at least post-operatively, because it is known from studies that the lens is most likely to rotate in the first hour post-operatively. If you're dealing with a large eye and you find that the lens is really freely spinning around even when you have rotated it, consider reverse optic capture. So this is a video to show you how you can do a reverse optic capture in this high myope. Now this is played really fast because I'm just showing you rotation to the desired axis, and that this lens really is spinning very freely. And what you do is get it to the right position, and then with 2 Sinskey hooks, you just lift the lens forwards to capture it. Of course, you need to have a rhexis that's smaller than the optic and well-centered. So in summary, rotation of the toric lens is safe and it's really not difficult. Preoperative calculation and planning are important. Accurate marking of the reference and intraocular lens axes are necessary. Prevent complications by having adequate retentive viscoelastic around the intraocular lens, and gently dissect to completely free the intraocular lens. Complete removal of the viscoelastic behind the intraocular lens after realignment of the lens is mandatory. Rest the patient for the first hour post-operatively to prevent re-rotation of the intraocular lens. Thank you very much.